Okay, so this is going to be the second part of this four-piece presentation on glial cell activity and neurological presentation within connective tissue disorders. In the first presentation, really just talked about the vocabulary and a little bit about neuroanatomy that is going to be relevant to understanding some of the neurological pathologies that we could be seeing within this population. So I know everybody wants to get to the part that is relevant to them. But really, if you haven't watched part one, please do. It really just describes a little bit more in detail of what I'll be talking about in the second part. And in the second part, I'm going to start talking about pathologies and a little bit more about connective tissue disorders. We'll get into more specific diagnoses in the third one. But just to explain why those with connective tissue disorders might have more of a problem with this neurological tissue maintenance or central nervous system homeostasis, right? So part one, background on anatomy. This part is going to go over pathology. So now we're going to get into why astrocyte and microglia dysfunction can wreak havoc and what that might look like symptomatically in an individual. Okay, so some of this is repetitive from the first one. So I am going to fly through those pieces, but the information is here because, like I said, I'd really like educational part, and that really is going to help build up an individual's understanding of what they're dealing with. So watch part one. I go into more of the detail on specific anatomy in part one, but just a reminder that the brain has an extracellular matrix and also has a basement membrane. These are composed of extracellular matrix and connective tissue, as are a lot of the barriers within the central nervous system that is supposed to be protecting our neurological tissue from any outside threats. Okay, so the extracellular matrix and the basement membrane in those with connective tissue pathologies might already have an increased risk to inefficiency, having difficulty dealing with threats, injuries, inflammation, things like that are trying to get through the barrier. If you have a genetic predisposition to a weaker barrier, you might have more issues with things getting through the matrix and membrane. Okay, so and that's the first dot here. If you have problems with the structure of the membrane, you might have more things getting through the membrane, and we really don't want things to be touching our neurological tissue. That's got a lot of work to do. It shouldn't be interrupted. We don't want to irritate it. And we do. We tend to irritate it quite a lot, which we'll talk about some of the triggers that can do that. We have many, many more triggers for our neurological system that we do now than we had even 100 years ago, unfortunately. From an article on connective tissue pathologies, where I'm going to be tying some of these in so that you can see the connections and correlations. Again, I don't like to give my opinion on stuff. I'm just going to give the science behind it, but I'm going to continue to weave these other ideas in so you can see how it all overlaps. And we're probably all talking about the same thing. And if we can understand that it might be as simple and complicated as neurological inflammation, for our neurological phenotypes in EDS, we can actually really start to figure out how to make people better. Um, in this connective tissue article by Malik and Koster back in 2021, they did find that there was a possible integrin issue, integrin communication issue. It's like a receptor problem in connective tissue pathologies. And we'll come to that a little bit later again. But the basement membrane, so the layer that the things happen at, communication happens at, again, it's not supposed to go through, it's supposed to meet the receptor and communicate, but things aren't supposed to pass through. It does have these integrin receptors on it to send signals to the matrix itself or the connective tissue. And that might also be impaired with connective tissue disorders. So, whether we're talking the same problem or a different problem, it confirms that we're seeing similar things over and over again. There's something going on with integrin receptors in connective tissue problems, and we also are seeing this integrin issue at the basement membrane as well. Collagen impairments specifically. So this is important to note. This wasn't a study that was done on connective tissue disorders. This was, and I'm sorry I don't have the article reference, but they're all within the summary. Um, it was just an article that was looking at basically the effects of something crossing in through the blood-brain barrier and what it does to the neurological tissue and the vascular, especially the neurovascular tissue in that area, which many of us tend to have problems with. So they found that collagen impairments specifically, also issue with laminins, but collagen impairments are linked to blood-brain barrier deficits and also cerebrovascular deficits or defects as well. So vascular basement membrane issues. So important to note for our individuals that do seem to have cerebrovascular issues, insufficiencies, compressions, things of that nature. There could be this component of blood-brain barrier deficits that we might be able to have a positive effect on to affect the cerebrovascular involvement in an individual. But specifically, collagen does seem to be important within our neurovascular structures. And if we have a collagen impairment, we might be more prone to having issues with the blood-brain barrier and the vasculature within the cranium, within the head. Okay. So with the extracellular matrix of the brain and the basement membrane, it's supposed to be maintaining the blood-brain barrier, which means we don't want things that are in the blood to get through to our neurological tissue. So it's supposed to be warding off that zone to get into the neurological tissue. However, abnormal composition, so the collagen problems, also laminins in individuals, can disrupt the barrier because if you have a less efficient barrier system and things are constantly knocking on the door, eventually there could be cracks in the system, there could be leaky junctions, and things are getting through. That can cause cerebrovascular issues and then issues with vessels in the brain. So sounds scary. However, in the population that I work with, we are seeing this marks. We're starting to test for it more, that we're seeing that there's some vascular insufficiency, and a lot of people do have amazing, interesting bodies that will figure out how to compensate for it. But again, if we can figure out how to support the blood-brain barrier better, reduce the inflammatory or injurious episode that happened, then we can possibly help put whatever's happening into remission. Conditions that will alter the blood-brain barrier that allows for things to get through that aren't supposed to get through, including things out of the blood and immune cells, are going to trigger this inflammation. And eventually the inflammation, if it's not helped, will lead to neurological dysfunction. And what that looks like is a little bit different for everybody. I'm going to break it down into the common things that we see, which you'll notice is common things that we see in EDS. So again, this might be as simple as our barrier systems are not as effective and we need to learn better ways to maintain them. So that chronic inflammation, neurological dysfunction that happens can actually cause remodeling of the extracellular matrix within the neurological system. So it causes this chronic self-perpetuating cycle of inflammatory responses that can make something called glial scars. And I air quote that because it's not really a scar, and we'll talk more about that in detail. They consider them border forming reactions that are happening as protective mechanism. But then there's also this change in excitability of neurons as well. So not just anatomical changes, but changes in excitability of our neurons. So we can have a hyperexcitability or also decreased neuronal function. And I'm going to break that down a little bit later because that's actually seizure activity or seizure-like activity and also neurodegeneration, which again is pretty darn common within our population. That blood-brain barrier, it separates the peripheral blood system from the environment of the central nervous system. We don't want the stuff in the blood touching the brain, spinal cord, and peripheral nerves. Unfortunately, sometimes it does. Okay, so this is just a repeat from the first presentation that I gave, but just a reminder that the components in the blood will only contact our astrocyte cells, so the communication cells of the neurological system within the brain and spinal cord, when the barrier has been broken down. So you're only going to have that interaction when there is injury or a disease process that's present. That's going to cause cellular, molecular, and functional changes. So it really changes the way that your neurological system is now functioning. And the astrocytes themselves can actually regress from what we consider mature, well-functioning, diverse astrocytes to immature ones that are not functioning appropriately. And they'll re-enter the cycle that they came from, perpetuating the immature cycle of astrocytes. And that's where we get caught in these bad cell cycles, unless we have somebody to help us break out of that. Okay, just a reminder of all the barriers. There's lots of different barriers. It's not just our, the blood and our neurological tissue. We don't want the blood to touch our cerebrospinal fluid. We want to keep everything separated out. So not going to go through all of these in detail. The articles referenced there, great pictures, simple pictures. I really like them so that you can understand them. But just to show that there's all of these different layers and barriers, and if those barriers break down, depending on where the individual is having a problem, it could give us a whole lot of insight as to how to help them. And I say that because look at all these here that we look at, and I think we think about the blood-brain and the blood-spinal cord a lot as one of the barriers. And yes, it's a big one that can cause a lot of problems. But then we have between the arachnoid, so one of the fibrous layers, and the cerebrospinal fluid, and then the blood and the cerebrospinal fluid as well, choroid plexus and the cerebrospinal fluid. So for those that are at a loss for what to do about cerebrospinal fluid management issues, if nobody has looked into this inflammatory process, which again, we'll get to in a moment, what can trigger that, then it's something to consider. And this is where we keep wondering, like with our population, well, why do they have to get more patches? Why isn't the patch holding? It could be because nobody has fixed this cycle that is impairing the barriers that you're trying to patch on. So we want the barriers to heal to be able to treat them. So, and this is not saying that we're preventing all procedures from happening, but I really am hopeful that give it another 10 years, and if somebody is looking at impairments in cerebrospinal fluid management, that they're also considering neurological inflammatory stabilization, so that we can hopefully have one procedure and that's it for long term. Okay. There is a first layer of the blood-brain barrier called the glycocalyx, and if that layer is damaged, then the blood-brain barrier is compromised. So that's typically how it starts, is the glycocalyx gets irritated, and there are other layers from there. Then this next little piece, again, this is repetitive from the first time that I talked, but just a reminder again that this can affect cerebrospinal fluid flow because the internal barrier that we're talking about is lined with what's called ependymal or ependymal cells, which is a type of astroglia that can affect cerebrospinal fluid flow and cause a disruption if the astrocytes are irritated, right? So we'll talk more about what astrocytes get irritated from, what they look like. But again, just to tie these things all together, we're talking about many, many different neurological conditions that can be fueled by neurological inflammatory processes and we'll just call it uninformed or poor maintenance of blood-brain barriers, because most people don't know how to take care of that barrier. We have more information on the gut barrier, right? The gut lining and improving the junction in that area, but not many people talk about the blood-brain barrier. Okay. So when there is a disruption at the blood-brain barrier, that is a common trigger for an influx of astrocytes to the area. So this is where it leads us into why we talk about astrocyte and microglia dysfunction, because individuals with connective tissue issues might be more prone to a disruption at the barrier, and that is going to cause this reaction of astrocytes to the area. Okay, and then we're maybe not the best at controlling it. Like actually, there are quite a few other genetic conditions and disorders and disease states that also have difficulty managing astrocyte and microglia activity. They did find that, just again to show like, hey, we're starting to understand some of this, that this astrocyte microglia part of it might actually start to explain some of the weird, wonky things that happen with whether it's spinal cord or head injuries or chronic inflammation. So they did find that epilepsy, so seizure-like activity, and mood disorders that happen after a stroke or a brain injury are linked to abnormal astroglial responses. So there is an alteration of the astrocytes that are supposed to be communicating appropriately and are not anymore. And if you have an injury that causes an astrocyte response like that, you could end up with an abnormal response in something like epilepsy or mood disorders. It is not saying that everybody will have that, but it's just to say, like, hey, there's probably an astrocyte response that needs to be maintained, managed, or at least monitored, right? And they see this sort of astroglial response in things like Alzheimer's disease and chronic pain as well. All right. So again, the structure and function of the extracellular matrix, the basement membrane, and the blood-brain barrier can all be altered when somebody has a connective tissue pathology. Those are all connective tissue structures. When we have repeated or continued chronic challenges or stressors to that tissue, to those barriers, then there can be an increased likelihood of, we'll call it glial scarring, or more appropriately, border formation, where it loses the malleability to be able to maintain normal functioning of the neurological cells and neurons. So it can alter the state of the perineural networks that I touched on briefly in the first part, and we'll get to again here talking about dysfunction. So the central nervous system, the spine, and the brain, injury or trauma to that area, and this can even be microtrauma over time, right? That can cause glial scarring or border formation at the neurological tissue as well. So we'll talk about these contributing factors in the third one as we're talking about tethered cord, as the components that go into that bucket analogy of all the things that we could possibly work on, and other avenues for beneficial treatment, if we understand the components that go into it. So again, I'll talk about that more in the third one. But any localized injury along with inflammation, um, that combination can actually wreak havoc on the system. And we do tend to see that a lot within our population. Specifically, this chronic insult to our neurological tissue, this chronic inflammatory process, this self-perpetuating cycle that we can get into, is going to disrupt that perineural network, and it's going to affect what we call synaptic plasticity, and we lose the malleability of the perineural network. In the first one, hopefully you listened to it, I talked about how the perineural network has to be malleable, that it really is a stable state of neuronal activity, and it responds to things that it considers threats. And then when the threat is subdued, it goes back to its stable state. That's the malleability of it. It's very versatile. However, if we lose the plasticity and the malleability, it can get stuck in the state of excitability of those neurons, because it determines how excitable that area is, if you're fighting something off or you're not, and things are safe. Very important to understand. There was a study that showed microglia degradation in the perineural network, so the spinal cord, that increases neuronal activity and increases the pain-related behavior. So just another overlap within the research that says microglia disruption to the perineural network is going to cause a hyperexcitability and increases the pain reactivity. So that's what we talk about, the hyperexcitability, and that might be why things like low-dose naltrexone, which works on microglia, is helping to stabilize chronic pain, is because we're actually reducing the excitability of this network. We're bringing it back down to a more stable state. So disruption of these perineural networks can happen for a variety of reasons. So again, this is the network where the communication happens within neurological tissue, this lattice-like extracellular matrix of itself. It can happen from injury, strokes, brain tumors. Connective tissue disorders themselves can also predispose someone to developing perineural network disruption over time. Um, because of the fact that we are more likely to have the barrier breakdown. The barrier breakdown causes astrocytes and microglia activity, which can disrupt the perineural network. It's like dominoes falling, right? So it puts you at increased risk to having an issue with the perineural network. Not everybody, but some for sure. Now you add in things on top of that: inflammation, viruses, injury, a stroke, and it can exacerbate the presentation, right? Bucket analogy. So what is going into your bucket that's making these perineural networks really angry? Those factors are going to increase matrix remodeling proteases. So in other words, it just keeps that self-perpetuating cycle going, right? It keeps things hyped up, and it's going to disrupt those networks even more, increasing the excitability, which will lead for some people to epilepsy and seizure activity. And I think this is really important for our population because I have met so many individuals that have seizure-like activity, but not really. And I have some individuals that, you call them functional seizures, or there's a whole group of different listings where you might not see something on functional MRIs and things like that, but the individual is describing what sounds like a seizure to you. That could be the hyperexcitability and this increased responsiveness of the perineural network that fires off like seizure activity. So extremely important to understand. Does it look like this for everybody that has a connective tissue disorder? No, it does not. I will say there are factors of other genetics that predispose you to also having a more reactive nervous system. There are other factors that go into the bucket, right? So not everybody, but some. And that's why I think it's important to validate the experience for some of those individuals of, again, if you haven't thought about this chronic inflammatory process that can happen, if nobody's talked to you about this, then please find somebody that can help you with the neurological inflammation part. So disruption to the perineural network exposes PV or parvalbumin expressing GABAergic neurons to a heightened oxidative stress. So it puts them under stress. It reduces the quantity of them and decreases the inhibitory drive. So that's just the science behind why you end up in a heightened state with easy excitability to your neuronal activity. Okay, so disruption of those networks and what it communicates with as well increases the tendency of seizure and epilepsy-like activity in those excitatory neurons, and it can also cause spontaneous seizures. So again, the individuals can be predisposed, not everybody, but for those of you that might feel like you fit into this category, please understand that there might be a reason, just based on your connective tissue, blood-brain barrier, these networks that you have. And if we can calm down the inflammatory response, restore astrocyte microglia function for you, and teach you how to manage this long term, the blood-brain barrier, and keeping it healthy and the tools that you need for flare-ups, it can actually hopefully reduce some of the issues that an individual is having. Okay, so a little bit more on seizure activity. So this perineural network disruption might be easier to facilitate if there's a connective tissue issue that can lead to the hypersensitivity and the hyperreactivity of this neural network, right? It can be exacerbated with any type of injury or inflammatory response to the central nervous system. Many people I talk to, if you listen to their story long enough, you're going to hear the perfect storm build up. You're going to hear that they were so stressed out and they just had a virus and it was just a small car accident. It wasn't that big. And then maybe there was a mold exposure around the same time and you just out there checking all the boxes. And those that have the perfect storm type of story do tend to have more of a this neurological presentation that's hard to break out of the cycle because you've thrown everything at the barriers and probably didn't have an efficient way to clean them out. So this combination of all these things, as the hyperexcitability of the system builds up for some individuals, not all, it can lead to the process of developing seizure-like activity in this heightened neuronal state. Okay. A little bit on psychology, and I'm going to sprinkle just some of these things in here. And this is really to overlap with our population to show like, hey, I think we're all talking about the same thing here. Maybe we can regroup at some point. But this perineural network disruption is also linked to schizophrenia, bipolar disorder, and autism spectrum disorder, which we have links for in hypermobile EDS. So, and hypermobility in general, I should say, across the board. So it would be interesting to see if we're actually all talking about the same thing, and these different diagnoses are actually also related to a biological barrier problem that might be assisted not in just psychology, but in biology as well. Now, we're going to talk a little bit about MMP, but a little bit more later. Again, that's just to talk a little bit more about what we see in hypermobile EDS with MMP specifically, but that's matrix metalloproteinases. When we block those, it can decrease the presentation of symptoms. So increased levels of these MMPs might actually increase the likelihood of these presentations. And why that's important is it's linking it back again with MMP that we see in HEDS. Lots of letters, I know, sorry. So this altered activity that we see in this perineural network is also seen in Huntington's disease and multiple sclerosis, and with Alzheimer's disease and schizophrenia, and the glial cells seem to be the contributing factor in dysfunction. So I have seen so many individuals who feel like they just overlap with these conditions, whether it's temporary with flare-ups, but difficulty controlling parts of the body, memory loss, and multiple sclerosis. I have a number of patients that have been scared with that diagnosis, and it can coexist just like anything else out there. But do you see all of the overlap now where we are seeing a lot of similarities between what we see in multiple sclerosis as an issue with the neurological firing system, and also what we're seeing with issues with the neurological firing system when you have a connective tissue issue. Okay, so we're going to go back to talking a little bit more specifically about the cells themselves. So why are glial cells so important? Why does Patty always talk about them? I will try to keep this concise because we still have a lot left to talk about. But glial cells, this is from the first session, so I'll fly through this. We really thought for a while that they were just filler in the brain, that they didn't really do anything. They were more structural. They didn't really have a functional role. How wrong we were. They are not structural only. It's pretty much the opposite. Glial cells they're the key to understanding neurological presentations, and especially neurodegenerative disorders and this neural network excitability. So at least we're starting to learn now which way we should be pointing our efforts. But glial cells really are this connection between the neuroimmune response. So they are constantly secreting extracellular matrix molecules. They're trying to maintain the 3D structure of the matrix. They're trying to keep it balanced. So glial cells help maintain the health of the neurological tissue, similar to mast cells that communicate and with their mediators with other tissues in the body. Astrocytes and microglia are the two main mediators in the central nervous system, the brain and the spinal cord. They respond to wear and tear that happens in the central nervous system, and they might be more active in those with changes in connective tissues because the barriers are more prone to letting things in. So you're going to have more responses from the glial cells because they're going to have more work to do. Okay. And just as a statement too, I know we're talking a lot about the central nervous system and the brain and the spinal cord, but it's this glial cell component, it's the neuroimmune key. The glial cells are the communication between the central nervous system and your peripheral immune system. So that's why, sometimes when I talk to people and they have tried everything for mast cell stabilization, Well, what about the nervous system? We might be able to go backdoor to treating the immune system by affecting the neurological system because they are absolutely connected through glial cell activity. Um, from the first one as well, but I just say, just to drive in the point of the importance, the principal function of the astroglia is to control homeostasis of the central nervous system at all levels of organization, from molecular to the whole organ. So it's a big deal. Astrocytes are a big deal specifically. It's a type of glial cell that's in the body. I talked more about this in the first one, so I'm not going to go into just anatomy with astrocytes. We're going to get more into pathology, but just a reminder that they deal with a lot of their own inflammatory mediators that they have bidirectional communication with. So these different mediators can trigger astrocyte activity. There's a ton of them out there that are going to make your astrocytes mad. Astrocytes, they can release mediators, again, very much like the mast cell, to heal or to harm the central nervous system in regards to pathologies. And it can actually affect the structural integrity of the extracellular matrix itself because it can continue the breakdown process if it isn't brought under control. With pathological conditions, there's an atypical synapse formation, so where the communication happens, and impaired neuronal plasticity. So we're seeing impaired function, we're seeing impaired structure. Astrocytes are going to alter the way that they look during physiological stress, and we'll see a picture in a moment. In nearly all central nervous system pathologies, astrocytes will become reactive. They change their morphology or their shape. They're going to change their molecular structure and also their function. So they're not doing what they're supposed to do anymore. So we have to figure out a way how to redirect them back to homeostasis. Okay, so similar to mast cell activity, astrocytes and microglia as well, which I talked about before, we'll get into a little bit more on that dysfunction, can have a pro-inflammatory or an anti-inflammatory role, depending on their state of agitation and their communication, and if it's appropriate with whatever they're talking to in the body. Okay. There are a lot of contributing factors that are going to affect astrocyte activity through these feedback loops, okay, with different structures. So astrocytes talk to neurons, microglia, anything that's getting into the blood-brain barrier. They talk to blood vessel walls inside the cranium and neurological tissue. So if there's an astrocyte dysfunction, the communication is not as efficient as we'd like to see, it's not correct, it's not sending the right signals, it can be sending the wrong signals also to blood vessel walls in the cranium, in the spinal cord as well. So just something to remember, that we can get caught in these feedback loops, and it can actually stimulate more of the problem. They will also attract more of the immune and inflammatory cells to try to help clear infection dealing with pathology, especially the more chronic it seems to get. It wants more help, and it's not always helpful, but it's trying to get more help because it's not finding homeostasis. Astrocytes don't directly synthesize that perineural network, but they do regulate it indirectly through their developmental functions. So basically, the communication that it's having with these other tissues is how the perineural network can get hyperexcitable because it's receiving the wrong input from astrocytes, right? So, and then this bottom piece from the first one as well, just to break it down a little bit, there are different types of astrocytes. These are just two different ones. Protoplasmic astrocytes might have more to do with synaptic transmission or communication, whereas the fibrous astrocytes might have a more supportive or structural role or metabolic compared to working with neuronal function. Okay, so here's the important slide. Okay, we got here, and we're only about half done. Sorry. So astrocytes, with the extracellular matrix remodeling, um, the astrocytes are going to take over that role in a lot of brain and spinal cord disorders and injuries. Um, and again, it can become pathological rather than helpful at a certain point. And those things that it is responding to, that it considers an insult or injury, whether it's acute or chronic, is not even limited to this list here, but just to give you a few. And this is where these are things to work on with a provider if you haven't worked on them yet. But if there's any brain or spinal cord trauma, And like I like to tell my patients, it doesn't matter what you or another medical professional thought the level of your trauma was. It depends on how your body interpreted it, right? So that's where, again, it's that perfect storm analogy. Your response to a minor whiplash incident that happens is going to be very different on the best day of your life versus a day where you can't take another thing happening to you, and you could have much more detrimental effects from that minor whiplash compared to another day. So, brain and spinal cord trauma is if anything sticks out in your story that you remember, any bumps to the head that were significant enough for you to remember and tell me, anything that somebody was concerned about. And the same for the spinal cord, like any sprains, strains, or any whiplash type injuries that you can remember from the past are going to be important to understand if there has been local trauma, physical in nature, that could be stimulating that feedback loop and contributing to it. That's what I preach all the time on neurological inflammation from toxins and this and that. But if we treat all your toxins and you still have localized dysfunction because we haven't realized that you have an unstable L5 and nobody's taught you how to appropriately stabilize it, you're really only getting half treatment and it's not going to stick. And we just have to make sure that we're seeing all of it, right? Ischemia, or lack of oxygen within the central nervous system, there can be many different issues or reasons for that. Infection, any type of infection, really, anything that causes inflammation within the neurological tissue. Okay, microbial infections, environmental toxins are a big one, especially mycotoxins as well with neurological inflammation. But there's also viruses, there's tick-borne pathogens and things like that. That this is where I think we're running into a problem with individuals that have connective tissue disorders after all I just said about the barrier being less effective. It's not that we have changed in more of us having EDS or some sort of connective tissue pathology. Our environment continues to throw things at those barriers, and our environment has gotten drastically worse with the things that we put into our body, on our skin, things like that, that we sometimes can't help. But we need to be taught how to support ourselves a little bit better if we have an issue maintaining the barriers. So environmental toxins, I know that there's a lot of individuals and professionals that scoff at the idea that you might be sick because of environmental toxin. But if you don't have a barrier defense system, it's something at least to look into and to check into with somebody who specializes in it, which I will say it is a different approach in working with somebody that might have altered responses to the immune system. So you can't just throw a detox at somebody. You have to understand how to work with stabilizing the immune system first, and then prepping the system, prepping the detox pathways, and then going for the detox itself. So it's a little bit different. There are some specialists out there. It really just takes listening to the individual and how they're responding. So don't throw environmental toxins under the rug. Bring them up to the surface if you haven't already and you're dealing with neurological inflammation. It's a long, slow process, but if that is part of somebody's story as to their neurological irritation, it can just, it's such a world of difference that it can lead long term in managing symptoms. Okay, tumors can obviously cause issues, metabolic disorders as well. There's a variety of reasons for that, including genetics, but it's just something to get checked out if it hasn't been. Seizure activity, so having predisposition to seizures, not just the connective tissue disorder that can predispose you to the perineural network excitability, but also having other genetic components or other conditions that predispose you to seizure-like activity is going to feed into this as well. And the same with neurodegeneration. So that's kind of like the chicken or the egg story with some of these diagnoses, right? But it's really when you start working on figuring out your treatment plan, it kind of looks like I say, it's like my suspect murder board that just goes up. Like you suspect everybody at first, and you slowly investigate each one to figure out where the most impact can be made. This is just a neat little um, diagram that I saw. So I threw some of these in there again. I got to show you guys science because it's validating too, right? So there are different types of astrocyte changes, and we're going to get a little bit more into this in just a moment, of the changes between excitability and also the changes in like anatomical composition. So there's a difference, but this one, it just broke it down into different types of diagnoses based on how the astrocytes are responding. And to tail off of that, reactive astrogliosis does seem to stem from trauma, infection, or autoimmune damage, okay, and causes neural inflammation, which is a beast in the system if it becomes chronic. Astrocyte reactivity can contribute to neurodegeneration or seizure-like activity as well. So that's a little bit of the difference between like the structural anatomy and then the reactivity or hyperexcitability. Okay. Also noted in the literature, astrocyte asthenia, or the loss of function of astrocytes, can be a contributing factor for some neuropsychiatric diseases out there as well. Okay. So now let's talk a little bit more specifically about the dysfunction and then what we see anatomically or functionally, right? This is the important stuff. So when there's astrocyte dysfunction that's happening, and this is connective tissue disorder removed, but we know this might be more prevalent because maybe we don't have the best barrier system. So at the focal lesion or the injury site, so whether it's a CSF, if you have like a venous fistula and you have abnormal CSF flow and it's irritating the spinal tissue in that area, that can cause a local or a focal lesion. If you have an area where you have a chronic stress fracture in your spine, or you have alignment issues, or you have abnormal spinal cord motion, which they find in some areas of the spine, if you have anything that happens locally within the spine or brain, so it can even happen within the cranium as well. We see dural scars sometimes for those that work on the brain manually. It's fun to work with. But what can happen is the astrocytes are going to form a physical barrier, and I'm going to talk about this in more detail, so hang with me. But this is referred to, it was called a glial scar, but it's not really a scar because it's a border formation that's composed of microglia, macrophages, meningeal cells, and fibroblasts. So it's this border formation that's actually trying to protect the area. But this can occur in the brain and the spinal cord. So again, I'll talk a little bit more about it here, and I'm going to talk much more about it in the third part when I break it down to the fact that the brainstem adhesions are, I think the statistic is like 99% of individuals with Chiari malformation were found to have adhesions around the tissue at the brainstem. That's really important to understand because something caused the adhesions, right? So if we can help this inflammatory process, we might be able to improve outcomes for people. The same with tethered cord. Tethered cord is this, talk about more specifically in the next talk, but it's this adhesion of the tethered or of the cord in place. So it's not pulled down like we typically think, but there's this adhesion that happens around the tissue. And that might be this border formation, right? It sounds, you'll see, it sounds like it's exactly what's happening in that area. So this is not saying that we can prevent all procedures from happening, but if we understand what might be contributing to the presentation of it, we can have much better outcomes. Okay, lesions can be from trauma, infection, and autoimmune conditions. So important to understand if you have any of those things that you have them looked at. I like this picture because when I was going through my neurological stuff and an N of one, I experiment on myself all the time because I have been blessed to be able to experience all of the things that my patients come to me with. But I couldn't explain this any better when somebody was trying to ask me what my brain felt like. It felt like the picture on the right. Like something was bigger than it was supposed to be and filling my head from the inside out and just causing all this pressure. But if you look at the difference between the healthy astrocytes on the left and the diseased astrocytes or the reactive astrocytes on the right, they actually become thicker when they become inflammatory and reactive. They change shape. That's the change in morphology. They change shape. So there's not a lot of wiggle room when you're talking about fluids to move in that space and cellular processes to happen. Now it's just taken up by these swollen and irritated astrocytes. So I really like this picture because it resonated with me and what I was feeling inside my cranium for a very long time, and also within the spinal cord tissue as well. For as hypermobile as I was, my neurological tissue felt like the picture on the right. It felt like it was just too thick. It felt like it was enlarged and swollen, and it didn't move very well. So that can happen if you have a change in the morphology and the function as well of those cells. So let's talk about the scarring a little bit that I think is very important. When astrocytes do become reactive through irritation, injury, reacting to things that are getting through the barrier, they can actually have that hypertrophy response that happens. So both the cell body and the processes that come off become hypertrophied or enlarged compared to what they were before. There are so many of them, and there's really not a whole lot of space in our neurological tissue, so it can start to fill space. Mechanical trauma will cause the protoplasmic and the fibrous astrocytes. So both of those have to do with structure and also communication to thicken their cell bodies in the process. Interestingly, in the cortex, a part of the brain, and the hippocampus, it can increase by twofold. So you might be more affected in the cortex and the hippocampus. And I'll tell you from talking to some other providers that work on brains and individuals with connective tissue disorders and neurological phenotypes, a lot of people are drawn to the hippocampus. And I'll stop there because I don't have an answer, but it's overlapping with the things that we're seeing in the potential causes and relations. The reactive cortical astrocytes might also be associated with seizure activity. So we do have that through the literature as well, with the disruption of the perineural networks or disruption in communication to the perineural networks. The astrocytes can become disorganized, thickened, they'll overlap in cases. It wreaks havoc on this system, right? If we break it down, so those fibrous astrocytes that might help a little bit more with the structure, they will hypertrophy, they will retract, and they will simplify. So they become kind of just stout in their presentation. The protoplasmic astrocytes will hypertrophy, but they'll have an increase in the number of processes and branches as well. Just interesting. Okay, here's the important piece as we're starting to understand maybe some presentations of low-riding cerebellar tonsils, Chiari malformation, and tethered cord in this population. So let's talk a little bit about glial scarring, or the layers that are involved. And now we call it border formation, but it kind of is like a scar, and it feels kind of like a scar in the neurological tissue. But, and this is a very simplified diagram of what it looks like. But if we have this area, this central non-neural lesion, right? So it's not neurological tissue, it's around it with stromal cells. They're connected, which is a connective tissue cell. There's fibrotic tissue, extracellular fibronectin, collagen, laminin. So interesting, collagen is in there, and we might have a dysfunction with that. So perhaps we're more prone to also developing this layered response because we have an abnormal collagen presentation for those that might have collagen variants, possibly. So the second layer is an astrocyte-formed border around that fibrotic scar. So this constrains the stromal cell where the scar is created. Okay, so astrocyte border around it. But then the surrounding zone of what we call the viable neural tissue, or what's salvaged neurological tissue, is spared. However, with the function, however, it is reactive and remodeling constantly because nobody's taking care of the astrocytes. So it's a protective mechanism to barrier off, create a whole separate barrier to try to protect the neurological tissue. And the area surrounding that border is constantly irritated and aggravated. So this could be a component of some individuals' presentation of cord tethering, adhesions, and things like that. Is this border formation that happens and will form a border around irritated neurological tissue. Reactive changes that happen around that lesion, they actually occur 3 to 7 days following insult, injury, inflammation that happens there. Um, this continuous repair and contraction will happen up to 2 weeks after the injury. And it usually takes about that long for the glial scar to be formed. Um, some people might remember, like, I felt this, I felt myself lose my mobility. Some people might not. But this is typically what we see, the acute response 3 to 7 days. And then over 2 weeks, we have this contraction and the scar formation that happens to try to protect it. The astrocytes that are closer to the injury will form that physical barrier that separates the lesion from the rest of the tissue, so it's trying to protect it again. Further from the site, the astrocytes are thicker and more overlapped. So again, we just have irritated astrocytic activity around this area. So the glial scar may be formed as more of a structural support, like a splint for the injured area. Isn't that interesting? So that's why, if you're treating tethered cord or whatever it might be, we still have to remember inflammation has to be addressed, yes, but then if it's forming this splint, like let's say the brainstem, we have to make sure that we're working on any upper cervical instability, brainstem compression. So it's unfortunately not as simple as just do one thing and you'll be better. We just want to make sure that we're getting all of the things to make sure that you are best better. And I'm going to throw some random stuff in there because I think it's interesting. I think astrocytes are fascinating. And what they did find that there's actually this naturally occurring change in astrocyte and dendrite processes during the menstrual cycle. So when estrogen increases, the astrocyte volume in the hippocampus decreases. So just to note that we do have hormonal fluctuations that influence astrocyte activity as well. Okay, so let's talk a little bit about microglia. We talked a little bit about the astrocytes and the astrocytes in this border formation that can happen, right? And also perineural network irritation causing seizure-like activity. But now let's talk about the microglia. When these are dysfunctional, it can cause issues clearing out all of the junk, right? So the extracellular matrix buildup that happens, the things that need to be cleared out of the matrix components from being broken down. So, and the perineural network as well being a different extracellular matrix. So if these are not working correctly, you don't have a good cleaning system and it can progress the pathology in the central nervous system. Okay. And I thought that this was just interesting, again, talking about we never want to say that's not connected because there will always be somebody in science that will prove you wrong with their body and their presentation. It's just what it is. So I'm talking a lot about issues at the central nervous system, the brain, the spinal cord, but we have to remember that there can be a peripheral nerve component as well because it communicates with the central system. So again, we want to make sure that if somebody is having a central problem, that we make sure it's not also being fueled by a peripheral issue. The old story of the thorn and the lion's paw. We want to make sure that we're finding the thorn too, even though we can calm down, hopefully, the angry lion, but we need to take the thorn out as well. So with this research, what they said is when we're looking at the dorsal horn of the spinal cord, so the level of the spinal cord, when there's a peripheral nerve injury, so nerve root, so where it exits the spine, so not central anymore, but a peripheral nerve injury, compression, irritation, whatever might happen there can promote microglia degradation and endocytosis of the perineural networks around those projected neurons. So it feeds back into the central nervous system. It irritates the central nervous system because of peripheral input. It gets angry and it tells the central nervous system, I am angry. And then you have this perineural network that's going to activate those projected neurons to induce pain-related behavior. So that's where we get central pain coming from with some individuals is there could be a peripheral cause, but because the peripheral nerves still talk with the same networks, again, we have to make sure that we have all the components. And it can be difficult, right? Because sometimes you have no idea what your layers are because there's so many layers, right? So what I say is we just start to peel back. If we get rid of this symptom and layer for you, tell me what's still left over. So you might get through working on so many things and you're like, ah, but still this left side of my lower back is still so irritated, but it's local now and it hurts appropriately, like it should hurt when I'm doing things. And somebody might have to look at that local piece, right? It's not always just central or just peripheral. There's usually an overlapping presentation. Okay. So microglia, they're supposed to be phagocytic, right? They're supposed to help eat things up, which would promote this scar-free environment after an injury because it's cleaning all that stuff up. You don't have all this astrocyte inflammatory reactivity. It would be cleaned up. But without them working correctly, you're going to increase the spread of inflammation. You're going to increase tissue damage. You're going to reduce recovery to spinal cord damage, right? So we need microglia activity also to be normalized. So astrocytes and microglia have to both be behaving. And again, low-dose naltrexone works on microglia specifically. So that's one part of the problem. And I do think it's very helpful. But again, we have to make sure that we're also doing something for the astrocytes if somebody has an issue with those as well. So a little bit different. During chronic systemic inflammation, neuronal dysfunction, viral or bacterial infection, healthy aging, dementia, the microglia are going to release pro-inflammatory cytokines. So as they start to break down, become irritated, they switch their role from anti to pro-inflammatory. So we have to make sure that we are addressing that. They act as the immune system of the brain, or the immune cells of the brain, and they can accumulate in areas of degeneration or injury to produce those cytokines to try to maintain homeostasis. But again, if it is too much, it's pro-inflammatory rather than helpful. When malfunctioning, those microglia can actually tap into the immune system, try to recruit lymphocytes from the blood to the damaged sites, which will continue to try to maintain homeostasis. But again, it's a dysfunctional way that it's trying to do it. It's really just reaching out for things to be helpful. And also our individuals might have issue in moving lymph. So again, this is just, we need to make sure that we are supporting. So sometimes lymphatic work can be very helpful for neurological inflammatory responses. Okay, so astrocytes and microglia and their interaction with each other will dictate the health of your central nervous system. There's a bidirectional cross between the astrocytes and the microglia. They talk to each other. It's not a one-way conversation. And they do this through releasing mediators, and that's the signals that get sent out. You release a certain mediator, the cell translates it in a certain way. When we have issues with crosstalk, we know that we have this in neurodegenerative diseases such as Huntington's disease, Alzheimer's disease, and multiple sclerosis. It's already out there in the literature. We know that there are similarities in these presentations as what we just see with astrocyte and microglia dysfunction. So just something to keep in mind. We are just starting to learn some pharmaceutical management for some of these. But again, remember, we didn't know that astrocytes did anything important until recently. So be patient with the medical field. We're getting there. It's going to take us some time. And as you can see, it's really complex, especially pharmaceuticals are going to help stabilize the reactivity. But if you don't work on the trigger that is stimulating the reaction, like chronic Epstein-Barr, then you're not going to have long-term solutions for an individual. Okay, so chronic glial irritation. And this is what I was just saying in the end of the last slide, if the trigger continues to cause the reactivity of the astrocytes and the glial cells, it's going to continue to spread inflammation. It's going to increase neural tissue loss. It's going to increase fibrosis that's happening in the local area, that glial scarring or border formation. So you need to control the trigger that is wreaking havoc throughout the body, right? Genetic conditions can predispose you to abnormal glial cell mechanics and responses, but it does not mean that you can't control it. It just predisposes you to being affected perhaps a little bit easier than the rest of the population and more severe with the symptoms. There's the formation of the secondary lymphoid follicles in response to viral infections with similar mechanisms that we see during the scar formation that's triggered by tissue loss. So trauma, ischemia, neurodegeneration, and other central nervous system issues. So just a crossover in the research between neuroimmune again, and just verifying that we are seeing this in other things as well. Chronic exposure to the irritants are going to alter astrocyte function, including the memory response that is going to remain until addressed. So remember, we can make those astrocytes turn into immature, not healthful astrocytes, and we push that back into the cycle, and that's all that we're going to get from here on out. So that's the memory that it holds on to, is this is how I'm supposed to work. But we don't want that to happen, because that's going to develop a tolerance or immune training that it seems like dampened responses to further stimulation. And there's something called immune system blunting. It's very similar. So even when the memory remains, you still have this dysfunction. So the issue's still there, but the reaction may be under the radar, even though you need to help it. So this is where, it's the idea of being close to the alarm bells at all time. That it's not a big jump. If your alarm system is here and your baseline is here, it's really not that far. It's really hard to tell, am I reacting? I don't know. I feel like this all day, every day. But now if you start to reduce the inflammation, you feel better. And we see this sometimes with people working on the mast cell component. If you improve things and now you put in an irritant, that reaction might feel more forceful or reactive because we don't have the blunting or the tolerance that we had before. That makes sense. So this isn't really a scar. This is important to understand. It's what's happening at the level of the neural tissue. It's more protective. It's compartmentalizing rather than scarring over, but it's still going to cause issues, and it still feels like a scar for people, right? Especially into the outer layers of more chronic irritation and inflammatory response. Remember, those are the reactive layers, are the outer layers. It's the inside that's formed this protective splinting system that's over it. It's border forming. It's a response to try to protect the neural tissue, but the border itself can restrict function and cause irritation if the trigger is not removed or the injury persists. So we'll talk more about that in my next talk, but you really have to remove the trigger of the neurological inflammation that's causing this. Treating it with pharmaceuticals and whatever it might be is only going to manage symptoms. It's not actually going to put anybody into remission. A note on MMPs. So this is where I talked a little bit about MMPs before. And this is just the crossover that I wanted to share on MMPs. It is related to what we're talking about. I'm not going to go down a huge rabbit hole with this, but specific. So this is the metalloproteinases. MMP9 appears to be the major contributing factor to perineural network disruption. Neurological insults will lead to disruption of that blood-brain barrier. The astrocytes are becoming more reactive. TGF beta is signaled, and that activates MMP9. Okay, so MMP9 is going to be activated when there's disruption of the blood-brain barrier. MMPs specifically as a group are these zinc-containing endopeptidases normally expressed by astrocytes, microglia, and endothelial cells. Okay, so they are linked to the presentation of astrocytic activity. MMP9 specifically is the most implicated one of the MMPs in central nervous system homeostasis. So it plays a very important role in pathologies as well. So not being helpful, it's a key player in extracellular matrix and perineural network remodeling, induced neuroplasticity, both physiological and pathological conditions. So it is helpful or it is not, just like everything in the body, right? But this is where we tend to push things into dysfunctional categories when we don't have internal stabilization. So it can become dysfunctional more so and lead to dysregulation of the central nervous system. MMP9 also has a large role in hippocampal dependent plasticity. So again, I throw that in there because I have so many providers that tell me they're picking up on hippocampal stuff in brains of those that are hypermobile. So perhaps there's more that might be affected within the hippocampus for individuals that are experiencing neurological inflammation, breakdown of the blood-brain barrier, and connective tissue pathologies. Okay, so these reactive astrocytes, again, when we have a dysfunction in the nervous system, are going to upregulate this MMP9, right? We'll see more MMP9 when there's a central nervous system pathology. It's associated with the perineural network disruption. They see it in studies when they look at seizures, traumatic brain injury, stroke, glioblastoma, so a type of tumor, neurodegenerative and neuropsychiatric diseases. We see reactive astrocytes that are causing perineural network issues. We see it already. What's interesting is that in those with HSD and HEDS, there is an enhanced expression of MMP9. So we're going to call that a correlation right now. It's not a cause or effect, right? But we're just seeing this repeated over and over that MMP9 is more prevalent in those with HSD and EDS. And perhaps that's because we need a little bit more help with our blood-brain barrier. And maybe we're already showing signs, even at younger ages, that we need more astrocyte and microglia support. Perhaps. Okay, so what regulates the extracellular matrix and the perineural network dynamics? It's the structural organization of the extracellular matrix and the perineural networks through intrinsic neuronal activity and extrinsic glial cell activity. Okay, so the neurons and the glial cells. Okay, structural organization might already be altered by connective tissue pathologies, right? So we might have a change in what our 3D matrix looks like. And the extracellular matrix structure and function will also change when threats are added into the system. So just reinforcing again that those with connective tissue issues might be more prone to neurological stuff happening. Thanks for making it. This was a tough one, guys. Pathology or pathophysiology. This is always a tough one to get through, but thanks for hanging in. So just a reminder of everything. HSD and EDS may not only cause issues the extracellular matrix in our classic presentation of what we think of as connective tissue, but also within the brain and the spinal cord as well. So this is really those barrier systems that are set up. We might have more problems with them. It's going to cause it to be less efficient and more reactive to irritants. And what that irritant is going to be individual for the person and what their body has been through. The helpful cells, they should be, the astrocytes and the microglia, they might have difficulty turning off and they're going to begin to cause local and peripheral issues throughout the nervous system. So they go from being physiological helpers to creating pathological disorders. And we see that a lot with different systems in the body. We just have to learn how to work with it and provide reinforcement like we can. And that's another talk, number 4. This might all affect neuronal and brain functioning. So in the functioning of hyperexcitability, neural degeneration, so we have the conductivity that might change with those perineural networks that are involved, or anatomically with astrocyte and microglia dysfunction, it can cause local scar border formation, so the border formation and adhesion to develop in the areas around the brain and the spinal cord itself. The astrocyte reactivity can also cause that hyperexcitability or the decreased neuronal functioning, so more of the perineural network involvement. And then what's really important is understanding this and finding appropriate treatment methods based on knowing the science and what an individual is presenting with, and then how to access a treatment point. Because if we can figure out what these global nervous system issues that seem to be everywhere are actually coming from, with the brain involvement and the central nervous system and the astrocytes and the microglia, we're going to have a better effect in treatment and more precise and possibly more options to play with as well for the individual. Okay, references. Thanks for hanging in there. This one was a brutal one, but to me, it's insanely fascinating to understand the connective tissue presentations and the neurological inflammatory piece that can help really explain and also help treat individuals with these neurological presentations that we see in hypermobile EDS and other connective tissue pathologies. So stay tuned for number 3 and number 4 in this series that I have. Number 3, we're going to really talk more specifically about CSF leaks and the tethered cord, and we're going to wrap it all in a little bit more validating into that one. All right, thanks for hanging in there, guys.